endocrine, his specialty. A little bit about him is that he is an endocrinologist specialist specializing in diabetes and metabolism with 15 years of medical experience. He focuses on helping patients manage complex hormonal conditions and diabetes-related health concerns. Dr. Varughese also holds expertise in internal medicine, allowing him to provide comprehensive care for adult patients with multiple health needs. His practice is affiliated with St. Joseph's Hospital and Medical Center, which is an award-winning healthcare facility. He earned his medical degree from Baylor College of Medicine, which is a prestigious institution known for training skilled physicians. He practices at multiple convenient locations throughout Houston, including the Houston area, it's in the medical center, right?
No, Sugarland and Memorial City.
Memorial City,
yes.
And Sugarland. His patients love him, and we have multiple residents here that actually use him, which is how we got connected with him. So you guys give Dr. Lipu a warm welcome and an applause.
All right. All right. Hello, everyone. All right. So let me trying to get my computer so I can see it too. All right. So let's talk about diabetes for a little bit. I mean, most of y'all know a whole lot of diabetes already. So this may be filling in the gaps of knowledge. Okay, so when we eat, we got food in that goes to the stomach. The stomach absorbs the food, and the food turns into sugar, and sugar is getting into your bloodstream, right? So in diabetes, what we're talking about is there's a lot of sugar in the blood and not in the tissues. And that is kind of the problem with diabetes. You have, the poem, water, water everywhere, not a drop to drink? It's that idea of there's plenty of sugar in the bloodstream, but not where it needs to be in the tissues and the muscles and the brain and so forth. So that is the process. So we'll continue on. So insulin, what it does is it opens the door to your muscles and the tissues so that the sugar goes from the bloodstream through the door. So think of insulin like the door key. So in type 1 diabetes, what happens is there is no insulin being made by the pancreas. So then you have a lot of blood sugar, and the red blood cells, you can see the little oval red blood cells, and the blue are considered the blue sugars. So there's a lot of sugar in the blood, there's no insulin to open the door for the insulin, the sugar to go in. In type 2 diabetes, there's plenty of insulin, right? But the door is locked shut. That's what we call insulin resistance. The tissues don't really respond to the insulin that your pancreas is making. So that's the difference between the type 1 and type 2. So, all right. So in a non-diabetic, we were talking about if you check your sugars in the morning fasting, the sugar should be less than 100. That's what a normal non-diabetic should look like. If it's pre-diabetes, you would see a blood sugar between 100 to 125. We call that impaired fasting glucose. The true way of knowing if you are pre-diabetic or diabetic is through the 2-hour glucose tolerance test. The sugar cola drink during pregnancy, that drink, the test, that's the true test to know for diabetes. We always use a shortcut, that's the hemoglobin A1C. And so anywhere between a 5.7 to a 6.4 is what we call pre-diabetes. And diabetes is when the A1C is more than 6.5. So why, we do the blood test every 90 days or so, right? There's a reason for that. The red blood cell that your bone marrow makes lives for 90 days. So what we're looking for is we take a sample of the red blood cell and see how much sugar is attached to it. And we're making inferences on how your sugars have been for the last 3 months. Because the red blood cells live for 3 months. Okay, so it is like a report card on how your sugars have been. So let's say your A1C is 5%. That means your blood sugar is somewhere in the 90s for the last 3 months. If it was 12, then you can say it was 300 blood sugar over the last 3 months. So 7 is around 150, 9 is around 210. So what's the big deal? Okay, so let's say that you have a lot of sugar in your blood, so what, right? there's two big category of complications. Number one is called the microvascular complication, meaning small blood vessel complications. We're talking about retinopathy, meaning the blood vessel to the eyes, so blindness, kidney, nephropathy, and amputations because neuropathy, because you don't feel the nerves, especially the feet. So you know how we say keep the sugars down, keep the sugars down? There's a reason that the UK PDS study showed that the higher the A1C, see the graph, it goes from 5 onwards, so the higher it goes, actually, I don't know if this pointer works. On a TV, it doesn't work, right? It wouldn't work on a TV. Right. So the higher it goes, the incidence per 1,000 years goes up. So think about it. 7 onwards, you can see the steepness, how steep it is. So that's why we kind of freak out at anybody above 7. We're like, hey, your chances of microvascular complications are a little bit higher. So a 5 and a 6 is an acceptable number. You still are not out of the woods, right? Some people still can have microvascular complications. So it's based on that trial that we had. Now, if you look at our body, we have insulin levels and we have insulin resistance. Insulin resistance is how much the body is fighting against the insulin, right? Not really working with insulin. So we have a normal amount of blood sugar, and you see the graph. Okay. So the insulin levels are higher than your insulin resistance in a normal scenario. And insulin resistance tends to go up with aging, genetics, normal resistance, all of those reasons. In a pre-diabetic, what we see is, isn't that black? That's why we can't see it. Okay. But in pre-diabetes or early diabetes, insulin resistance goes up, and your body is able to match that with increasing the insulin levels. So if you think about it, this would be what normal is, and insulin resistance starts going up higher. Why is it higher? Because you have obesity, you have steroids, we have lack of exercise, aging, genetics. Normal resistance is about, everybody has some kind of insulin resistance already, but it keeps going up from various factors. This is what normal insulin would be. Your body adds more insulin, but it generates more insulin. So it's trying to keep up. In prediabetes, your insulin levels and insulin resistance is somehow in balance. But what happens later on is it goes out of balance, right? So we'll come to that. Prediabetes in general is not benign, okay? It is not, it's okay type thing. Because some people who later on become diabetic will find out they already have startings of retinopathy. Around 12.6% of patients progressing from prediabetes to diabetes over 3 years exhibited background diabetic retinopathy, meaning they're already having signs of diabetes already. 80% of the pancreas beta cell function is not even working in prediabetes, so it is not a complete benign thing. Okay. All right. So if you look at the beta cell function, so beta cell function is what the pancreas, the cells that make the insulin is called the beta cells, and how much the beta cells is doing is called the beta cell function. And when we start seeing the blood sugar in the 160, 180, 120 range, the beta cell function is already going down. That's 85% loss of beta cell function. And in diabetes, it goes close to 0, right? So prediabetes is not completely benign. That was the emphasis here. In type 2 diabetes, your insulin resistance is so high, it overwhelms the body and the insulin levels are not enough. So you see, insulin levels, your body's trying to keep up, but it's not able to, right? Insulin resistance goes beyond that. All right, so the pathogenesis of type 2 diabetes. We have so many different ways where diabetes is affecting. One is called the decreased insulin secretion. Pancreas doesn't make a lot of insulin. There's decreased incretin effect. That means the gut is not responding as well. There's the fat in your tissues are also breaking down to produce more sugar. The kidney starts reabsorbing a lot more sugar. The muscles don't absorb a lot of sugar. The nerve in your brain, the neurotransmitter dysfunction also happens. and there's increased glucagon that's being made. All right, so there's several factors, and we use the medications on the different parts of the problem. Okay. All right. Complications of diabetes. So most common complications. So I was talking to you earlier about microvascular and macrovascular complications. So macrovascular complications are the big blood vessels. We're talking about strokes. We're talking about heart attacks. And the blood flow to your lower extremities as well. So heart disease, stroke, peripheral vascular disease, it can happen at any time, and it's unrelated to your sugar control, which is the not so fun part of it. The microvascular, the small blood vessel, is very related to the glucose. So if you get your A1C down in the 5 and 6, you know how I showed the graph earlier? If you're somewhere in the 6s and 7s or even the 5s, your chance of having a microvascular complication is a little bit lower. You're pretty safe, right? We're talking about kidney, eye. That's why I tell people when the sugars are really well controlled, you don't have to really worry about kidney problems or eye problems or nerve problems, skin, stomach, and all that. You still do have to worry about the heart, the brain, and the lower extremity. So the way we manage the macrovascular complications is A, B, C. A1C is for A is for A1C, for glucose check, and A1C is a check. It's a memory check over the past 3 months. B is for blood pressure, right? So that's why we harp on the blood pressure too, right? And then C is for cholesterol. And the cholesterol, we got different cholesterol numbers, right? You got the HDL, which protects your heart. I call that a report card on your exercise. That's kind of the only way to bring up your HDL. LDL is the bad cholesterol that can clog your blood vessels and lead to heart disease. Triglycerides are directly related to how much fried food you're eating, right? And you can see it directly go up when you eat more oily and fried foods, which also is a secondary risk factor for heart disease. All right, let's talk about kidney disease real quick. The high levels of blood sugar can put an extra stress on the kidneys. And after years of damage, kidney starts to leak. And the useful proteins that we need in our bloodstream start leaking into the urine. And that's called microalbuminuria. The proteins that are supposed to stay in the bloodstream is leaking into the urine. You know the urine test that we do every 6 months to a year or so? That's what we're looking for. Is there early signs of leakage by the kidney? The analogy that I use is the canary in the coal mine. That's an early sign of, hey, is the kidney unhappy with the sugars? So the urine test comes positive first, and as years go by, microalbuminuria becomes macroalbuminuria, meaning there's a lot of blood, protein that's lost in the urine. Then you get frothy urine. Then, after several months or years, is when you start the kidney number in the blood work going down. So the blood work doesn't go down first. The urine test shows up first. That's why we do the urine test, to find anything early. So if the kidney loses its filtering ability, then the waste products build up in the bloodstream. And that's when finally the kidneys fail. That's why people are on, we call it ESRD or end-stage renal disease. They're on the kidney transplant list, or they need dialysis. So who gets kidney disease? I mean, there's multiple factors, right? Sugar is one of them. Genetics is another one. Blood pressure is a big one. I kind of call it, it's a high pressure pipe, your blood vessels, right? And if the pressure is high, you're going to tear a hole in the filter, right? So blood pressure is an important piece. Most people I see, the sugars are really fairly well controlled, but the blood pressure is out of control. So that kind of hurts the kidneys. Blood sugar is definitely important. I'm not denying that. Yes. So nephropathy, or the kidney damage, happens to 10 to 21% of diabetic cases. And 43% of the new cases of end-stage renal disease are attributed to diabetes. Different populations, higher risk. Type 1 diabetes are definitely at a higher risk, 12 times higher, 4 times higher in African American, 4 to 6 times in Mexican Americans, 6 times higher in Native Americans than the general population of diabetes. So different people, different groups are more and more affected. So let's talk about eyes real quick. Yeah, okay. There's a higher risk of blindness from diabetes, and many have minor eye disorders. Early treatment is very important, right? Glaucoma, cataract, retinopathy, all are potential complications from the eye. Okay, when we say diabetic retinopathy, this is a general term for all the disorders that can happen on the retina. Retina is the nerves in the back of your eye, right? That helps you see. And if there's retina is affected, it is called retinopathy. And diabetic retinopathy means affected by the diabetes. There's two types of retinopathy. There's the non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. The proliferative kind are the more serious kind. Okay, show and tell. This is what normal retina would look like, okay? And so we have the middle, the circle is where your macula and your fovea is, where you can see and the visions are. Now, in a non-proliferative diabetic retinopathy, you have small blotches. Can you see the flame and the dots and the cotton wool spots? There's these small flickerings of things. That's early. This is what, oh yeah, there you go, that's even better. Yeah, that's where it gets a little bit more advanced. There's more bleeding in the eye. Okay, that is still non-proliferative diabetic retinopathy. High risk proliferative diabetic retinopathy is when the blood vessels are so fragile, they're so friable, a little bit of spike in your blood pressure is enough to kind of make it bleed. So if you have bleeding in your eye, it's called proliferative diabetic retinopathy. The sugar makes everything grow, even in the nerves of the eyes. So, and the blood vessel in the back of your eye starts growing faster. But even though they're growing fast, they're not very well built. So they're more leaky. So they bleed a little bit easier. That's what a high-risk proliferative diabetic retinopathy looks like. So what they do is, have you heard laser done in your eyes before? This is what it would look like. They're lasering all the spots where it has blood or the new growth in the eyes. All right. So when we talk about having your eyes checked, there is a diabetic screening guideline. In a type 1 diabetic, we always say screen at least from the diagnosis time, at least 5 years later, start diagnosing. In type 2, we say start checking your eyes every year from the day you got diagnosed with diabetes, because we may not even know how long you had the prediabetes for, right? Or the diabetes for. So because of that uncertainty, we say, hey, go ahead and check it early. Start checking right away. Okay, now, there's two common types of neurodamage. There's a sensory motor neuropathy, also called peripheral neuropathy. That's where people get the tingling and the pain and the numbness or the weakness in the feet. Right? That is peripheral neuropathy or sensory motor neuropathy. And it usually happens in legs, okay? But it can happen anywhere too. Usually happens in legs. The way I kind of explain it is the railroad track from the brain, the farthest is the feet, right? So that gets affected first. All right, and then we have autonomic neuropathy, meaning we have no control over our heart rate or our stomachs, right? There is nervous signaling going automatically. That is called the autonomic nervous system. So that gets affected. When that gets affected, that's when I keep hearing people who say, I feel full all the time. I'm nauseous all the time. That's digestive problems. People get vomiting. People have diarrhea or constipation. Problems with how well the bladder works. Problems having sex. Dizziness or faintness. Loss of typical warning signs of a heart attack. They don't even feel the heart attack. They feel tired or just pressure. That's it. Loss of warning signs of low blood sugar. Increased or decreased sweating. Change in how your eyes react to light and dark. Those are all signs of autonomic neuropathy. So gastroparesis is when there is nerve damage to the control of the stomach. It leads to poor muscle control of the stomach and intestine. Movement of food is slowed or stopped. That's when people get heartburn and the nausea, vomiting of undigested food, early feeling of fullness when eating, weight loss, abdominal bloating, blood sugars all over the place, lack of appetite, gastroesophageal reflex, spasm of the stomach wall. These are people who had a very high sugar for so long that the nerve to the stomach gets affected. And so the complication of gastroparesis is that it just becomes a lot harder to manage the blood sugar because we have no idea when the stomach actually digests the food. And so some people get bacterial overgrowth and leads to fermentation of the food that's sitting in there. All right, foot complications. We get skin changes, calluses, foot ulcers, poor circulation, and amputations. So that's why we got to take care of the feet, right? And so definitely look at your feet, inspect it, because in neuropathy, if you have an ulceration or you stepped on a nail or something, you may not even know about it, right? So that is why you actually have to look at it. Look at your feet occasionally. Smoking is straight up bad, right? Okay, it decreases the blood flow to your feet and it makes everything worse. Acanthus nigricans is a condition where there's a tan or brown raised part of the skin on the neck or armpits or groin. It's usually you see people or especially they're overweight and they're diabetic or have high insulin levels. Losing weight actually helps. Something that we don't realize is sometimes people have depression from sugar being high. So definitely talk to your doctor about it. Poorly controlled diabetes can cause depression-like symptoms. High or low blood sugar during the day may make you feel more tired or anxious. Low blood sugar can lead you to be hungry and eating too much. Low blood sugar in the middle of the night can mess up your sleep. High blood sugar in the night can make you frequently urinate and feel tired the very next day. My analogy is the Snickers commercial. You know when I forgot the actor. She was all right, I was lost. When you eat the Snickers, you feel better. The sugar gets you feeling a little bit better. All right. Heart disease is caused by narrowing or blocking the blood vessel to your heart. The blood vessel usually carries oxygen and nutrients to your heart, and when the vessels are partially or totally blocked by fatty deposits, a heart attack can happen, right? It can happen at any time. This is something everybody probably knows already, is where the cholesterol build up that can lead to a atherosclerotic plaque. And there was a study that showed that improving your blood pressure, even by 10 points, 154/87, if they change that red line to a 144/82, your chance of having a heart event is even a little bit less. That's how important even 10 points matter. And then there was a study that showed cholesterol pills helped. That's, actually it probably went too far, huh? Okay, that's another study. It's about a study showing how we came to the conclusion that cholesterol pill would help with heart disease. It lowers your chance of heart events, like heart attack or stroke for that matter. So there are many complications of diabetes, right? Complications can be minimized by good blood glucose control. And so it is important on how to control your sugars. Okay, so how do we treat diabetes? Okay, I am clicking way too fast on this, isn't it? Okay, lifestyle modifications. That's number one. Okay. Oh, yeah, you got it. Okay. So lifestyle modifications. That's number one for diabetes. You got to have a low-calorie diet, increase physical activity, and then behavioral therapy. Behavioral therapy means changing your way of eating your desserts, I suppose. There's plenty of that here, isn't it? Yes. Okay. I mean, first of all, it's not a race, right? It's a marathon, right? We got to pace ourselves. I mean, if you say, from now on, I'm not going to eat any more sugar ever in my life, that's going to end fast, like in a week, right? But if you say, I want to eat dessert only for the weekends, maybe a little bit more doable, right? A little bit more practical or realistic. So ultimately, there is an importance on low calorie. There is an importance on physical activity because you know how we talked about diabetes, that insulin's not there, right? Or insulin's not working really well? The only tissue that doesn't really need insulin and can straight up drink the sugar from the bloodstream is your muscles. So So if you start exercising, your muscles will drink the sugar and it will go away from the bloodstream. So let's say you eat something bad. The punishment is 20 minutes of walking right after. Because the muscles will drink up the sugar and the sugar levels could come down. Okay, so we'll come to that. So there was a bunch of people who did a study. It's called the Diabetes Prevention Program. Okay, they took a group of people who were overweight, who were around 51. They randomized it into 3 different categories. There were intensive lifestyle, there was a metformin group, and a placebo group. So what happened is, when they started the trial, the lifestyle people lost around 7 kilograms. So that's what, 14 pounds in the first year of the study. Most of them did lose some weight, right? They were doing a trial, right? People talked about food and diet and exercise and everything. So they did that, and they slowly crept back on the weight, okay? However, the people who did the lifestyle changes, even by 4 or 5 years later, 58% of them did not become a diabetic. These are pre-diabetics we're talking about. So if we gave metformin to the other group, 31% of them did not become diabetic. So my point is, if you are pre-diabetic, there's no pill that I can give you to prevent you from diabetes. Maybe I can give you metformin. It may bring it down by 31%. What is more important? Lifestyle and exercise. In this study, the way they did their lifestyle exercise was just 200 minutes a week. That was it. That's a low goal, isn't it? 200 minutes a week is what?
3 minutes a day.
Yeah. There you go. And those 58% of the people did not become diabetic. All right. So if we have to treat, okay, there's several medications out there. Most of them, what we're trying to do is lower your insulin resistance. So metformin, Actos, GLP-1s, all lower the insulin resistance so that your body is still making insulin, right? May not be a lot, but maybe a little bit. That can still function. So that's part of the goal. So you heard of metformin before, right? $4 pill. I mean, it used to be $4 before COVID. Now it's like $10 or $12. It's relatively safe, no hypoglycemia. What it does is, when you eat during the day, your sugar turns into fat, and the liver stores it up for the night. When we're not eating at night, the fat in the liver will turn the fat back to sugar during the night. What metformin is doing is, telling the liver, hey, don't make any more sugar at night. We got plenty around here, so don't make extra. Right? That is all it's doing. But you can't give it for a patient with heart failure or liver failure or kidney failure. And stomach trouble is usually the biggest side effect it has. Pioglitazone is another one. It's another older drug that we have. It turbocharges the insulin. Basically, it lowers your insulin resistance, so the insulin will work a little bit better. Problem is, you can't give it for a patient who has bladder cancer or heart failure. The good news is it lowers your chance of another stroke. Okay? And it's good for those with fatty liver. So, let me see, is there another? Yeah, there you go. Part of the problem in diabetes is there's fat in the wrong places. If you look at it, you have sumo wrestlers who are very overweight, right? Or who are pretty heavy. And then we have the regularly overweight people. There's a difference. The sumo wrestlers have it all under their skin. The diabetics usually have all the fat in the gut, inside, in the liver, in the wrong places. And that is usually the cause of most trouble. That's actually why we're starting to look at fatty liver and liver failure and cirrhosis and stuff, because fatty liver is making diabetes, or people turn diabetic faster. Okay, so here in this image, you see that there's fat in the liver, fat in the belly, but the medication that I'm talking about will take the fat from the liver, it will put it under the skin. Okay, so it doesn't lose any weight, you're just pushing it in the right places a little bit. Then you probably heard of this ones, right? Farxiga, Invocon is not even there anymore, Jardiance. I call it a sugar pee pill. You pee out all the sugar in the blood, from the bloodstream into the urine. It improves your weight, it helps blood pressure, it helps the blood sugar, it lowers your risk of heart failure, but you can't really give it to a patient who completely has a kidney failure. The problem with it is the Invokana that got pulled out of the market is because they had a toenail, lower extremity amputation. And DKA and genital infections are some of them. This is the more popular one nowadays, GLP-1 agonist. You've probably heard it all over the place because it's now very popular. Ozempic is one of them, Mounjaro is another one, and Victoza and so forth. What it does is it makes you feel full, so you eat less and you lose weight, right? So it's great for weight loss. It's good for diabetics, it's good for the fatty liver, it's good for obesity in general. However, it is expensive, right? It is an injectable. There are pills out there now. It has a lot of stomach trouble. You can't give it in patients who have pancreatitis and who anybody with a family history of medullary thyroid cancer. So if it is all good news, what is the bad side effects? If you start losing weight on these medications, and if you don't exercise, what's going to happen is you lose a lot of your muscles. Okay, you lose fat, but here's the analogy. If you muscles are easier to chew on, fat is like rubber. Okay, so your body would prefer to eat the muscles, so you lose weight, but muscle loss is the biggest side effect. So anybody who's on these medications, and they're starting to lose weight, definitely you have to exercise. There's no way around it because you could be worse off than you ever started, right? So greater risk, greater reward. There is greater risk too for that medications. You probably heard of these medications. It's called DPP-4s. It's a weaker version of the injectable we talked about earlier, Onglyza, Januvia, Tradjenta. No real side effect because there's no real benefit to it either. It's very little. It is still expensive. Yes, it is. But I mean, if your A1C is what? A 6.7 and you want it to be a 6.3, perfect medicine. You see my point? Very little bit. If you're 9, this is not going to do it. Okay, so if we ran out of our options of pills or shots, then we got insulin to work with, right? If we can't lower the insulin resistance in the story, then we can increase our insulins, right? Artificially, right? And that's where people take insulin. Actually, before we do the insulin, there is a pill that we can give. You heard of the glipizide, the gliberides, right? Glimepiride. These are pills that will raise your insulin. Problem is, the study here, all these lines basically shows that it works for first 2 years, then it stops working. It works only for a few years, okay? And then the inevitable usually happens where you have to use insulin. So let me show you the whole rigmarole about insulin. Insulin, rapid-acting insulin, works right away, or at least 20 minutes later, and then it stops working in 8 hours. Then we have short-acting insulin, or the regular insulin, that lasts longer. Intermediate insulin is NPH, which that's the Humulin N, if anybody knows that one, it works for 12 to 14 hours. And we have, next one. Yeah, long-acting insulin is Lantus and Toujeo and Tracebas and all that. That works for like 20 to 24 hours. So, in a normal scenario, everyone who has good blood sugar control, whenever you eat your breakfast, as BLD is breakfast, lunch, and dinner, anybody who eats any food for that matter, sugars will go up. It is expected, it is a normal response of your body for the sugars to go up. So when you eat breakfast, sugars will go up, but in a normal functioning pancreas person or non-diabetic, the sugars will come down, right? And so it will come down, and sleep, your blood sugars come somewhat stable. In a diabetic, what happens is when you eat the breakfast, lunch, and dinner, the sugars shoot higher than the normal person. So if you're normal, in a normal scenario, blood sugar may go up to 160, and that's it, after you eat. In diabetic, it goes up to 200 or 250 or even 300, right? majority of them will come down, but most of the time it doesn't. Even here, I don't know if you can see, breakfast goes up, you're a little bit higher. Lunch, it doesn't always come down. It may stay up higher. And the dinner goes up and you stay high. So in a diabetic. So what we're trying to do is, by giving long-acting insulin, you're trying to bring the whole thing down. So you wake up with a very good number. That is the whole point of the long-acting insulin. So when you do long-acting insulin, it will bring the blood sugar down to a normal level. Or, let me see. Okay. So at least with a long-acting, so how do you know if your Lantus or Toujeo or Tresiba or any of the long-acting insulin worked? Is by checking your sugars in the morning. If your morning sugars are great, you know that dose worked. If not, the dose has to change somehow. So what we're trying to achieve is, when you sleep and you wake up, your sugar should be great. And that's what the long-acting insulin, Lantus, Tresiba, Toujeo, and all those things do. So it still doesn't address the mealtime problem. Everybody who eats food for breakfast, lunch, or dinner, or any other time, the sugars will go way too high and it doesn't always come down. So that's actually why we give the insulin for food. So you say, hey doctor, you're giving me so many insulin, so 4 shots a day, are you crazy? This is the reason. There are different purposes to them. So when you do the mealtime insulin, the sugars won't spike as much. And that's the point of it. Next slide. So then finally, when you do the 4 shots a day, now you are mimicking what normal physiology would look like, or what normal blood sugar would look like. All right. Okay, next slide. All right. So if 4 shots a day, or, the insulin for food is only when you eat. If you eat only once a day, then only 1 shot, right? If you're eating 4 times a day or 5 times a day, then you take shots of mealtime insulin whenever you need to, which can get cumbersome for some people, right? And that is why we have the pumps. You've probably seen or heard of insulin pumps. These are pumps that would check, the sensor that you check the sugars with can tell the pump what to do, and the pump can give you insulin 24/7. They give you like a drip of insulin every hour, on the hour, and modify the insulin doses according to your sugar levels. And there's several of them. These are just show and tell. I just wanted to show the pictures of them. And these are some of the sensors that check the sugars. We have Dexcom and Libre, and they're a lot smaller now. But these continuously check the sugars, which is great for most people, but if your kids are looking at them, not so great. And then you heard of weight loss surgeries, right? So this is a gastric sleeve. Basically, they make the stomach a lot smaller. And then you probably heard of a gastric bypass too. These are all bariatric surgeries. For some people, this is a good way of treating diabetes. The gastric bypass probably gives them 5 years of I call it 5-year warranty. The statistics show that at least for 5 years you won't have diabetes. The gastric sleeve will take diabetes away at least for 3 years. Everything else beyond that is on you, right? If you keep the healthy lifestyle or diet, you could get away from having diabetes ever again, right? But typical story is 5 years on the bypass, 3 years on the gastric sleeve. Okay, so then the question becomes, can I cure my diabetes? We kind of call it like cancer. We don't really say you're cured. We say you're in remission. Diabetes can go in remission. So it is up to how we're doing on our food and our exercise. It is something that can be managed, especially with the newer medications. At least if you do one medicine, or to getting in the fat out of your liver or your belly, you could have diabetes that can go into remission. All right, that's all I got. Any questions, tell me. Ask. Yes?
I've been reading a lot lately about the good effects of having cinnamon. Can you talk about that, please?
Yeah, so the question is about the good effects of cinnamon. I actually don't have good data, or I don't know for cinnamon. I think for me, I would say it doesn't hurt. So go ahead and try. Especially if you have a sensor, you can know how the sugars are doing. But I haven't had anybody who tried it for me to know. Yeah.
It's a very old,
It is, and there is a thought that if you cook it, it doesn't have that effect. So it's uncooked that would help more, but there's no real trial to show me that data.
another one is honey that they're encouraging. What about honey?
Ooh, okay. Honey is like fruits. Fruits are good for you, right? Fruits are good for you. Actually, that's fructose, right? Fructose. Fructose has more of a liver problem than regular sugar. However, if you eat an apple, at least you won't eat the donut, right? So go ahead and eat the fruit. So that it is a lesser of the two evils, is the way I would look at it. But honey,
They often mix it with other things like cinnamon.
yeah,
And of course, and you see this come across your web and you think, what are those guys doing?
it's okay to try. I mean, if you have a sensor, you'll know better. But I don't have a one way or the other. Yes. Oh.
That way people can hear.
Diabetes and stress level.
Yes. Okay. So there's a hormone called cortisol that your body makes to deal with stress. You know, adrenaline, right? Fight, fright, flight response. This whole fight and flight response, you get the sudden boost of energy. Somebody's trying to attack you, you get a sudden boost of energy. Energy comes because a hormone raises your sugar. Sugar is energy. So if your adrenaline levels go up, your sugars will go up. So if cortisol is a stress hormone and your body is trying to fight a stressful event, it will give you the energy through glucose. So if you're diabetic, now your sugars are very high, right? Your body doesn't necessarily know the difference between a physiological stress, or physical stress versus psychological stress. Meaning, if you're stressed mentally, it will give you the same response as you have physically. Somebody attacking you, or you're a hospital, you have an infection. It doesn't distinguish between the two. It will raise your cortisol in both scenarios, and it will raise your sugars because it's trying to give you the energy to fight whatever that was.
They probably, at one time, I had some surgery late in the evening. The next morning in the hospital, they did my blood sugar, it was over 400.
Yes. So
And that was probably a result of the surgery.
yes, physical stress plus anesthesia. The anesthesia also causes your sugars to go up. Oh yeah, there's a question in the back.
Gosh, this is fabulous. That beautiful picture you showed of the retina with the multiple areas that have been laser photocoagulated, what is the status of the retina? Do those areas no longer perceive light? In other words, is this decreasing your visual acuity?
There is a potential to affect the visual acuity. However, if they spare the macula, where you are actually seeing the vision is centralized there, then you're somewhat safe. But it is very possible that that's the next place where the bleeding happens too, right? So, yeah.
Any other questions? Henry, do you have some keys?
What's your opinion on fake sugars? Replacing sugar with,
Yeah. So the question is about using artificial sweeteners in food. There's a couple of ways to talk about it. For diabetes, per se, for the sugar's sake, it is okay. If it is cravings, it may not be okay. It actually may worsen it, where you actually feel hungry again and you may actually crave the real sugar later. Because you are tricking your body, and the body does get wise to this at some point, right? So sugar, it's okay. Cravings, not so much. For weight loss, it doesn't help a whole lot there because it is not truly non-calorie. And then for liver, there is a concern that it may affect the liver. So, yes, yes, no.
I think there was another question on this side.
Yeah.
You had one, Schneider?
Tracebo.
Yes,
You usually get it for the overnight dose.
yes.
The blood sugar was like so overnight. So the placebo's changed for daytime.
So Traceba has more than 24 hours long action. It can work for 30 hours too. So it has a little bit of stacking effect to it. So that may be why they change it to the morning is one option.
Well, the morning, it's smoothed out, usually about 112 to 114 like
Oh,
that.
that's good.
But I'm just scary because I was told, you take your Tracebo at night. And, but that's okay.
It is okay to take it in the morning, yes. It's easier to take it at night, but it's totally okay to do it morning. All right.
Any other questions? Okay, I don't think so.
Oh, and then one last thing. There, for insulin, because there's a lot of shots, right? I forgot to add, there is a new insulin too, that's an inhaled insulin, it's a powder. You can whiff it, and it works right away. That's a new type of insulin out there. And then if you have anybody who is type 1 diabetic, there may be more people who are autoimmune in the family. Tell them, have them checked, because now we have a medicine to delay type 1 diabetes, at least for 4 years. So buy them 4 years, right? If you have a 6-year-old granddaughter or grandniece, you can at least give them 4 more years is a big deal, right? So those two other newest things, yes?
What about the GLC-2 pills?
GLP-1 pills?
Yeah.
Actually, what about them?
Well, they've been newly approved by the FDA.
So the GLP-1 agonist injectable that we have that's once a week, they just reformulated it into a pill. So the effect is the same. It's still good. The sugars we do see very good sugar control, but the annoyance is you have to take it every day, and some of them are on an empty stomach. But yeah, go ahead. Yeah.
So it's a question about the pre-diabetic and the type 1. If the A1C bounce between 6.3 and 7.5, or is there a way, or by some healthy act that we can further reduce down to 5? 5, the 5-ish.
That's a hard one. I mean, getting to 5 is a tall order, but if you did from 7.3 to 6.4, that's already a pretty good improvement, right? So if you drill down on that a little bit more, you can get there. Or the GLP-1s, I have people who started GLP-1s with the 6.4 and got it to a 5. That's an easy 5, but with medication. I don't know if you're okay with that idea though, right?
It has to continue exercise.
Yes. Yes.
All right, let's give Dr. Varughese another round of applause. So glad you guys came. Thank you all for being here. Enjoy the rest of your evening.